with Hem-Onc emergencies, trying to cover the things that I think you will most likely be asked on the boards, and we try to do that as visually as possible. It's a bit of a dry subject. We're going to try to make it sing. Our first question. This patient presents in respiratory distress with dilated neck and arm veins, conjunctival edema, neck swelling, and this truncal rash. The most likely cause of this condition is A, tuberculosis, B, small cell lung carcinoma, C, non-Hodgkin's lymphoma, D, renal cell carcinoma, E, prostate carcinoma. And okay, 59% of you said small cell carcinoma. That is correct. Back to my slide, please. This is the superior vena cava syndrome. The most frequent cause nowadays are tumors. The most frequent tumor being small cell lung carcinoma, followed in frequency by non-Hodgkin's lymphoma. There are several non-oncologic causes of superior vena cava syndrome. The two most likely cases there being a idiopathic inflammatory condition called fibrosing mediastinitis, and patients who have indwelling central venous catheters that coagulate. Patients present with plethora, cyanosis, periorbital, and conjunctival edema. This is the condition where if you suspect it, one of the ways of trying to differentiate between a sudden onset of a new condition and just somebody who looks like that is to ask them for their driver's license. I doubt that'll be on the boards. Same patient. The methodology of choice to secure this patient's airway with this clinical picture and chest radiograph would be A, endotracheal intubation after the administration of succinylcholine and etomidate, B, blind nasotracheal intubation, C, endotracheal intubation after vecuronium and etomidate, D, awake intubation with optional fiber optic scope, or E, translaryngeal jet ventilation. I don't think this type of, this is going to be on the boards, but this is sort of help you in your practice if you're ever confronted with this situation. And 49% of you have the correct answer, which is D, awake intubation with optional use of fiber optic scope. That picture was actually from not from a small cell carcinoma, but the X-ray was a non-Hodgkin's lymphoma, mediastinal mass causing the superior vena cava syndrome. This is the patient who, if you use paralytic agents, you will get a circulatory collapse because the compression of the tumor on the superior vena cava will drop the cardiac output precipitously. So this is a very, very difficult, and because there can be upper airway edema, this is an extraordinarily difficult airway. If you're fortunate enough to have an anesthesiologist with you to help you manage this patient, it would be helpful, but at least know that this intubation in this condition using paralytic agents is fraught with danger. Okay, question number 3. Which one of the following is not accurate about this condition, the condition illustrated by this MRI scan? A, pain may precede weakness by weeks. B, patients in whom this is suspected should have a rectal exam in the emergency department. C, the faster of onset of symptoms, the worse the prognosis. D, breast, lung, and prostate cancers are the most frequent cause. Or E, glucocorticoids are not effective in palliating this condition. Shall we vote? All righty, 36% have gotten the correct answer. This, of course, was an image of a spinal cord compression from a tumor that started in the vertebrae and spread into the spinal canal. So this is spinal cord. This is oncologic spinal cord compression, which occurs in 5% of cancer patients. And again, it's mechanical compression of the spinal cord by either metastatic or locally advanced disease. The largest proportion of cases, as we saw in this MRI scan, it was extension into the epidural space by vertebral body metastases. About 10% of spinal cord compressions are cervical, 70% are thoracic, and 20% are lumbosacral. The pain does precede neurologic findings by weeks to months. The pain is often described as a band-like pain, worse on coughing or straining, often associated with distal tingling that spreads proximally. The weakness in these patients can be unilateral or bilateral. The late signs include urinary hesitancy, perianal numbness, and rectal sphincter weakness. Glucocorticoids are effective in palliating this condition. So it would be if you suspect it, there'd be no harm in most cases to giving the patient a bolus of glucocorticoids. Okay, next question, a 28-year-old male patient presenting with this blood smear and this radiograph. The most likely reason for the pain is A, osteoarthritis, B, septic arthritis, C, bilateral aseptic necrosis, D, salmonella osteomyelitis, E, hemophilia. Shall we vote? Bilateral aseptic necrosis is the correct answer. Just to point out that the smear is a smear of a patient with sickle cell disease. There is a prominent sickle cell there. Those are the platelets, and a number of target cells, which is commonly seen in a number of hemoglobinopathies. And we'll be asking a series of questions about sickle cell disease now. Because I believe this is one of the more likely things that you'll see on the boards. It's important to remember that patients with sickle cell disease have their cells sickled both when they're in crisis, which is usually when we're seeing them, and when they're out of crisis. So the presence of sickling cells per se does not indicate anything about whether the patient's in crisis. Bilateral aseptic necrosis is a relatively common complication of sickle cell disease. It results from infarctions of both, or patients with sickle cell can get infarctions of both the bone and the bone marrow. It can cause other musculoskeletal syndromes, include the hand-foot syndrome in children. This will be covered extensively in our pediatric presentation, so I don't want to get into it. Patients commonly have compression of the vertebrae, as well as shortening of the cuboidal bones of the hand and feet. And in this case, the radiograph showed necrosis of the femoral heads, progressing to joint destruction. A lot of the patients you'll see in your emergency departments with sickle cell disease will have had hip replacements. Bone marrow infarction can cause fat emboli, and this is seen most frequently after parvovirus B19 infection. These may be other factoids that would become useful on the boards. Next question, again, it's the same slide, so we're asking now a question about the genitourinary complications of sickle cell disease. Which of the following is not a complication of this condition? A, priapism, B, microscopic hematuria, C, chronic medullary infarctions with isosthenuria, that is urine that's at the same concentration as blood, neither dilute nor concentrated urine, papillary necrosis producing a kidney stone-like picture, or E, testicular cancer. Not a complication of sickle cell disease. Shall we vote? Excellent. Testicular cancer is not a complication of sickle cell disease, while the rest of these are. We have because of poor blood flow to the renal medulla, we have an impaired concentrating ability. We have papillary infarction, hematuria, and renal tubular acidosis. Priapism, those of us who've practiced a number of years probably see this 2 or 3 times a year. It tends to recur in the same patients, can be a complication in as many as 40% of the males. There are 2 peaks for priapism, one in the 5 to 13-year-old group, and 2 in the 21 to 29-year-old group. Comes from engorgement of the corpus cavernosa, whereas the corpus and the glands in the corpus spongiosa are not involved most frequently. The treatment is subcutaneous terbutaline, and if that doesn't work, you can actually do lavage of the corpus cavernosa with a mixture of saline and epinephrine. That usually works. If anyone's done it, it looks brutal, but the patients get a lot of relief. And I believe this is our final question about sickle cell. Which of the following best describes the pathophysiology of this condition? So I'm trying to get at what the underlying defect is. A single amino acid substitution impairs the sodium pump in the red cell membrane. B, a single amino acid substitution leads to changes in the oxidation status of heme-bound iron. C, the red cell is missing a key enzyme to respond to oxidative stress. D, the patient's spleen is overactive, leading to red cell membranes. Or E, a single amino acid substitution leads to abnormal polymerization of deoxygenated hemoglobin. Tried to make this question a little bit more difficult. I think if the boards were to ask this, they would get to this level of detail. Shall we vote? Excellent. 67% answered correctly that it's a single amino acid substitution. The hemoglobin is deoxygenated. When it's deoxygenated, it forms abnormal polymers, which leads to a bunch of problems. Just to the background, the trait is seen in 8% of the United States black population, and we see the disease in about 1 in 600 African Americans. The severity of the disease is inversely proportional to the persistence of fetal hemoglobin. So if they ask what's the most important characteristic that leads to mild attacks or mild disease, it's the persistence of fetal hemoglobin. We already said that the abnormal polymerization as a result of a single amino acid substitution is the problem. Initially, the abnormal polymerization occurs in only the deoxygenated state, and this leads to abnormal red cell surface characteristics. So the spleen and the lymphoreticular system pick these cells out. They have a shortened lifespan, so there's a chronic extravascular hemolysis. And eventually, the cell becomes, because of this sort of the chronicity in the condition, and some of the endothelial responses to the abnormal red cell membrane, eventually the cell remains in this abnormally polymerized hemoglobin regardless of the oxygenation. And that's why, although we administer oxygen to a lot of these patients, it doesn't work, because by the time the disease progresses, the cells are abnormal, and the interaction between these abnormal cells and the endothelium is chronically abnormal. And we're going to now go through a number of questions about coagulation, and I can guarantee you I'm not going to show you any pictures of the coagulation cascade, but because I don't think that from an emergency medicine standpoint that type of thing is going to be asked. But this is a very important area, and I think in years future, increasingly, there's just a lot of new knowledge here. The role of the vascular endothelium, and there's a tremendous amount of information coming out, which I don't think are going to make it on the boards. Just a quick word about the plasma coagulation proteins. The proteins are to replace an unstable platelet plug with a stable fibrin clot, obviously as a sort of a teleologic defense against trauma. And so we have this complicated cascade of proteins that are circulating in their inactive, which is also called their zymogen form. And then there's a series of stepwise changes that occur. When one is activated, it then activates the next one. Factor 7A is the only protein that is circulating in the active form, and the final common pathway of this system is the activation of factor 2 by factors 10A and 5A. We think of this as two systems, the extrinsic and the intrinsic system, which is really an in vitro characterization. And we have the PT that looks primarily at the proteins that are involved in the extrinsic system, and the PTT, which looks at the proteins that are primarily in the intrinsic system. And I've listed those for you there. I really don't think that's going to be on the boards. And the only point I want to make is that this is an in vitro distinction. And these are the lab tests that we have to look at the coagulation system. And I suspect there could be some questions about the various lab tests. So the only point I wanted to make was, in reality, there's not two systems. There's one system that responds to different types of stresses. And the way we characterize it is really more of a function of the lab tests that are available that look at the specific proteins that are involved. So with that introduction, we have a 30-year-old woman presenting with a prolonged nosebleed. The following is noted on physical exam. I point to you where the abnormality is. It's not in the teeth. Which statement is the most accurate? A, this rash usually represents an infection. B, the patient has a problem with her plasma proteins. C, the patient may be taking warfarin. Or D, the patient's platelet count is probably below 50,000. Or E, the patient's platelet count is probably below 20,000. Shall we vote? Good. So this is basically a petechial rash. We can go back to the slide then. Petechial rash, which is characteristic of thrombocytopenia. And you don't see the petechial rash until the patient's platelet count is usually below 20,000. A few quick words about thrombocytopenia. There are 4 causes of thrombocytopenia. Platelet underproduction, which is usually associated with the pancytopenia. So those patients, in addition to having a low platelet count, will usually be anemic and will often have a low white blood cell count. Increased destruction. And there are 2 types of increased destruction, two general causes of increased destruction. The immune-mediated, which is either autoimmune diseases such as ITP, collagen vascular diseases, or HIV, or drugs. And the 2 leading causes of immune-mediated thrombocytopenia are quinine and heparin. The non-immune-mediated causes of thrombocytopenia, and we'll be asking some questions about these later, include DIC, sepsis, and eclampsia. The other 2 causes are usually sequestration of thrombocytopenia, usually in the spleen, associated with some of other hematologic diseases often, or something like Gaucher's disease that gives you an infiltrative splenic enlargement, and just the fact that there's a large spleen will trap platelets and give you a systemic thrombocytopenia, and finally hemodilution. So this is a quick review of thrombocytopenia. The next question, this patient is taking warfarin for a prosthetic heart valve, has an INR of 11, but no other evidence of bleeding. The patient has a tense arm after minor trauma. The best management in this patient would be A, transfuse 5 units of platelets. B, stop the warfarin for 3 days. C, administer 15 milliliters per kilogram of factor VIII concentrate. D, administer 5 milligrams of vitamin K IV. And E, administer 5 milligrams of vitamin K IM. Okay, so we were evenly divided between the vitamin K choices. There's a lot of literature here, and I've tried to sort of distill a few rules for you, which are in the handout. But most life-threatening bleeding in patients who are on anticoagulants is intracranial. Patients in whom you have suspected intracranial bleeding should get fresh frozen plasma plus 10 milligrams of vitamin K IV. This would probably, sort of a compartment syndrome of the arm, which we presented here, would be in the serious bleeding category. Most texts would recommend giving IV vitamin K, which has an effect beginning in about 6 hours. PO vitamin K, about a 2.5 milligram would be the normal dose, works within 24 hours. If you give too much vitamin K, there's warfarin resistance, which could cause you problem for whatever the reason the patient was on the anticoagulant in the first place. And some anaphylaxis has been reported with IV vitamin K. So you only want to give it if the benefit, which in this case would clearly outweigh the risk. Same sort of situation. Which of the following is not considered a bleeding risk factor in patients taking warfarin? So this is sort of your question to look at what the underlying conditions are that will predispose a patient toward who's on a warfarin for serious bleeding. A, high INR. B, old age or older age patients. C, recurrent intercurrent illness requiring antibiotic therapy. D, continuous administration of warfarin for more than 1 year. Or E, a history of alcoholism and liver disease, which is not a risk factor for bleeding in patients who are on warfarin. Excellent. 67% have nailed the answer. The bleeding risk factors are divided into two major and several weaker associations with bleeding. The two major risk factors are the older age patient and patients who have a higher target or a higher actual INR. That should be of no surprise to anybody that you're more likely to bleed if your INR is long. In addition, females, patients with a history of cerebrovascular disease, patients with a history of hypertension, alcoholism, and liver disease, patients with recurrent illnesses who are on antibiotics, and patients during the first year of their anticoagulation therapy are more likely to bleed, as opposed to patients who've been stable on their anticoagulant therapy for a long period of time. Okay. Which of the following statements about warfarin therapy is true? A, patients starting on warfarin should receive a 3-day loading dose. B, warfarins inhibit the synthesis of clotting factors in the bone marrow. C, warfarin exerts a procoagulant effect by inhibiting the synthesis of proteins C and S. We'll talk a little bit more about these proteins later. D, warfarin therapy is monitored by measuring the PTT. And E, orally administered warfarin is well absorbed and has a 6-hour half-life. Right, 34%. Go to the next one. Okay, so warfarin works in the liver. It doesn't work in the bone marrow. And inhibits the hepatic synthesis of the vitamin K-dependent clotting factors, which are 2, 7, 9, and 10. Therefore, it's measured best by the PT, as well as 2 regulatory proteins that are basically anticoagulants. And those are protein C and S. So warfarin will inhibit protein C and S. So if you start someone on warfarin initially and you use high doses, it's actually procoagulant because protein C and S have a shorter half-life than does factor 2, which is thrombin. So consequently, this is the reason that when we are anticoagulating people, we start with a heparin usually, or a low molecular weight heparin, and start warfarin at the same time. If we just started warfarin alone, because the half-life of the protein CNS is shorter than the half-life of the thrombin, initially the person would become more thrombophilic, would be more likely to clot. And higher initial doses of warfarin do not do you any good for this reason. That's the reason that we start people on a steady dose of warfarin. There's no loading dose. Warfarin is well absorbed orally, but the wrong response said it had a half-life of 6 hours. It has a much longer half-life, and that's an important fact to know. Again, we said we follow it with the PT and INR. The INR is an international normalized ratio. What it does is it adjusts for the fact that the test itself involves the addition of an extrinsic factor called reagent, or thromboplastin, to blood, and then measuring the amount of time that it takes to clot. These thromboplastins have different intrinsic activity, and the INR is an attempt to allow you to take the results from one lab and generalize those results to another. So it accounts for differences in the activity of the tissue thromboplastins used for during the measurement, during the lab test. So again, don't think it'll be on the boards, but important to know. Okay, one more warfarin question. An otherwise healthy young patient taking warfarin for prosthetic heart valve has no symptoms, but routine monitoring found their INR to be 8. no bleeding, no nothing. Recommended treatment would be A, administer fresh frozen plasma at 15 milliliters per kilogram. B, administer 10 milligrams of vitamin K IV. C, stop the warfarin for 3 days. D, stop the warfarin and administer vitamin K. Or E, administer vitamin K plus 15 milliliters per kilogram of FFP. Shall we vote? Well, stop the warfarin for 3 days. So this is the situation that we're often confronted with. No bleeding, but a prolonged INR. And the general sense is that the risk of bleeding exceeds the risk of the thrombosis. I mean, I'm assuming that people are on warfarin for a meaningful condition. If somebody's on it for a questionable condition, then that might not be true. But if, as in the case we gave here of somebody with a prosthetic heart valve who is at risk if they become, if they lose their anticoagulation, it's basically recommended to use PO vitamin K when there's no bleeding and the INR is greater than 9. And it's recommended to stop the warfarin for patients with an INR between 4.5 and 9. And it's been well studied. Most of the patients will bring their INR PT back into the therapeutic range. And this is really not accurate and will not normalize. It will come back to the range that it should be within 3 days. So that's the sort of a rule of thumb and where to start people in terms of stopping their warfarin and remeasuring. Okay, let's move on to some questions about unfractionated heparin. A common, I mean, there'll be many more issues about the situations that we use heparin later in the course, in MI and PE, et cetera, et cetera. We're going to focus a little bit on the basic points of pharmacology on heparin. So which of the following is most accurate about unfractionated heparin? A, it is a protein that is highly positively charged. B, it works directly by inhibiting the production of fibrin. C, it's best measured with an INR. D, it can only be administered intravenously. Or E, it works indirectly by increasing the activity of antithrombin 3. Shall we vote? Okay, the answer is number E, or 5 here. It works indirectly by increasing the activity of antithrombin 3. So what do we need to know about heparin? It's a naturally occurring polysaccharide that works by binding to antithrombin 3 and increasing its activity. Antithrombin 3 then inactivates activated thrombin, which is 2A, as well as activated factors 9 and 10. In that way, it prevents coagulation from occurring. So it works at several different places in the coagulation system, in the coagulation cascade that I promised I won't show you, and it's not in the book either. Heparin, unfractionated heparin, is a naturally occurring product. It's a biological. It's made from grinding up the spleens of cows and pigs and so on and so forth. And it consists of the varying chain lengths that leads to a very variable activity in any given patient, and that's why it needs to be monitored so closely. But there's only a very small portion of these long polysaccharides, a pentasaccharide, a 5-sugar group, that's really responsible for the key activity, the bringing the antithrombin 3 in contact with factors 2A, 9A, and 10A. And for that reason, we'll see that it's been modified and there are other products that are available, but it's still widely used and it still might pop up on the boards. Heparin is highly negatively charged and has a very high plasma protein binding that in part leads to its, the unpredictable activity of it is due to this protein binding. Okay, let's switch then our focus to a question about the newer product, low molecular weight heparin, which is certainly a topic that's fair game for the boards. So which of the following statements concerning low molecular weight heparin is true? A, it's a genetically recombinant product. B, low molecular weight heparin exerts most of its activity through release of tissue factor inhibitor from endothelial cells. C, the dose of low molecular weight heparin is unchanged in renal failure. D, it exerts most of its effect through its interaction and its inactivating factor 10A. And E, protamine cannot be used to reverse the effects of low molecular weight heparin. So let's vote. Well, good. We have a plurality for answer D, and that is, in fact, the answer. Low molecular weight heparin is also a naturally occurring product. It's not genetically engineered, but it's manufactured from beginning with unfractionated heparin, and it's treated in a way to give shorter, more homogeneous polysaccharide chain lengths. So it works in just as regular heparin does. Low molecular weight heparin works indirectly by increasing the activity of antithrombin 3. However, because the chain lengths are shorter, it does not bind as much to thrombin, to activated thrombin, as does unfractionated heparin. It works mostly through factor 10A, which is further proximal in that coagulation cascade. And because of that, because factor 10A is a multiplier effect, it's very effective by inhibiting coagulation at that level. It works just as effectively as unfractionated heparin, which works at both factors 9A, 10A, and 2A. So that's where it works. It does not bind to plasma proteins. It's well absorbed from subcutaneous sites. And because it's such a regularly, because of the uniform chain lengths, its pharmacology is much more predictable than the pharmacology of unfractionated heparin. However, you must adjust the dose of low molecular weight heparin in renal failure, and there are algorithms in your book for that. I don't think they're going to ask you on the boards how to do it, but I think you should know that dose needs to be adjusted in renal failure. Protamine, which is, remember we said that unfractionated heparin was very negatively charged. Protamine is very positively charged. It binds unfractionated heparin very well. It binds low molecular weight heparin less well, but somewhat, so that if you have a patient with life-threatening bleeding, you can administer protamine. You will not get as immediate or as full a procoagulant effect as you will if you're reversing unfractionated heparin. The algorithms for the dose of protamine in patients who are bleeding with low molecular weight heparin are in your handout. I don't think they will ask that, but I think you should know that protamine is partially successful. Okay, a question about disseminated intravascular coagulation and basically the causes of DIC. And DIC should be suspected in all of the following conditions except A, placenta previa, B, gram-negative sepsis, C, promyelocytic leukemia, D, severe trauma, and E, microangiopathic hemolytic anemia. The plurality has the correct answer. It's placenta previa. DIC is a widespread activation of systemic coagulation leading to the combination of thrombosis and bleeding. There's thrombotic occlusion of the small vessels, and then a consumptive coagulopathy occurs where that pathway just keeps on going and consuming the precursors of the coagulant proteins. The diagnosis should be suspected. It's in patients who are thrombocytopenic. Some of the lab parameters of DIC include prolonged PT, prolonged PTT, increased fibrin split products, and the low level of coagulation inhibitors. So all three of these conditions can be tested for and should be present if the diagnosis of DIC is made. It is present in all of the conditions that we listed here except for placenta previa. Promyelocytic leukemia is this one acute, it's a variant of acute myelocytic leukemia where particularly DIC is associated with it. It's a very rare condition. But DIC is seen with abruption, not with placenta previa. So that's that question. 15. This is a transfusion reaction question. A patient receiving a transfusion has a brief shaking chill, but looks well and has a clear plasma, if you were to draw it and spin it down, and urine that's completely clear, no evidence of blood. The emergency physician stops the transfusion and determines that it's the correct unit. Which of the following statements is the most accurate? A, the transfused unit must immediately be returned to the blood bank. B, the transfusion could be continued if there is no evidence of intravascular hemolysis. C, a frequent complication of an intravascular hemolytic reaction is status epilepticus. D, this reaction is most likely caused by preformed IgE in the recipient's serum. Or E, the reaction could have been prevented by premedicating the patient with diphenhydramine. Good. Excellent. This is a febrile transfusion reaction. This is not a hemolytic transfusion reaction. And this is a relatively common situation where the recipient's antibodies react with components in the transfused unit to release cytokines, or preformed antibodies in the transfused units react to the person. It's actually not clear from reading the literature whether it's a host problem or a unit problem. But nevertheless, it occurs in about 0.5% per transfused units. It's seen more frequently in patients who receive multiple units for transfusions. So the key thing, if you have somebody in whom you suspect a hemolytic, the serious transfusion reaction, is to stop the transfusion, check the unit, and look for signs of hemolysis in the blood, in the urine, perform a Coombs test and a haptoglobin. If there's no hemolysis, you can continue the transfusion. There are people who have allergic reactions to transfusions where the main manifestation of the reaction is urticaria. Those are the patients who get better with diphenhydramine if you premedicate them to avoid such a reaction in the subsequent unit. A febrile transfusion reaction, diphenhydramine prophylaxis will not work. Give the patient some Tylenol and continue on. Which of the following condition is not associated with an increased incidence of DVT? This is just a picture of somebody with a clinically obvious DVT. Okay, let's vote. Excellent. 63%. The thrombophilic state is seen with either an increase or abnormal coagulation factors or a decrease of the antithrombotic factors. So in factor V Leiden deficiency, or that's not deficiency, but it's someone who has a genetically abnormal factor V, it makes activated factor V resistant to inactivation by protein C. It's a rare condition. It's not that bad. The most serious of the thrombophilic conditions are patients with a decrease in antithrombotic factors, and the worst of these is antithrombin 3 deficiency. It's usually familial. Patients will often know it when they come in. Heparin and low molecular weight heparin will not work in these patients. You have to use a directed thrombin inhibitor in those patients. And it is seen in all the conditions that we mentioned except for hypercholesterolemia, but it is seen in hyperlipidemia. So thrombophilic state, seen in patients with antithrombin deficiency, polycythemia vera, Crohn's disease, nephrotic syndrome. These are all people, if they have relatively minor complaints that could be a DVT, you should work them up. Okay, next question. The most common cause of hemorrhagic death in patients with hemophilia. This is a giveaway question. I think I already gave you the answer on a previous slide. Here are your choices. Let's vote. Excellent. Intracerebral hemorrhage is the most common hematologic cause of death. HIV is still the leading cause of death overall. Hopefully over time that will go down. Hemophilia, just to remind you, is a sex-linked coagulopathy caused by a genetic defect found on the X chromosome. So men are much more likely to have it since they only have one X chromosome. There are two types of hemophilia. Hemophilia A, where there's a genetic absence of factor 8. Hemophilia B, where there's a genetic absence of factor 9. Male patients with hemophilia have levels of these coagulation factors that are less than 1% of normal. Females who are carriers of the disease have levels of these factors which are about half of normal, which is plenty to give them a normal coagulation pattern. You'll most frequently see these patients with spontaneous bleeding into joints, so they'll come in with joint pain. This leads to a chronic synovial inflammation, and they'll eventually get deformed, immobile joints, very similar to the joints that are seen in patients with rheumatoid arthritis because they develop what is like a chronic aggressive synovitis. And there's some more points about hemophilia in the handout. Given modern screening techniques, our next question, given modern screening techniques and viral inactivation techniques, which of the following diseases is most likely to be transmitted via the use of plasma-derived replacement factor concentrates? So basically for hemophilia, there are two types of replacement factors, those that are derived from pooled plasma sources and those that are a genetic recombinant product. So the question here is, which of these diseases is still, in the modern day and age, with all of the screening tests that we have, could be transmitted via the use of plasma-derived replacement factor concentrates in hemophilia? Shall we vote? The answer is hepatitis A. So basically, these replacement factors, as we said before, nowadays, for the plasma-derived ones, it's much safer than was previously available. There's aggressive donor screening and viral inactivation techniques that are applied to the product. And the viral inactivation techniques will get lipid-enveloped viruses. However, the two that are most frequently missed are hepatitis A and parvovirus B19. So just, I don't think they're going to get to this level of detail. All patients who were treated before 1985 are going to be hepatitis C positive. And just the algorithm, factor VIII concentrate increases activity by 2% per unit per kilogram weight. In patients who you're treating with just a normal joint bleeding, joint pain, you'll try to get their levels up to about 25 to 30% of normal. And most of us will speak to the patient's hematologist and work with them on the dosage. But I think this might be important to know. Switching back to oncology, I think for our last question or two, this has to do with which of the following tumors does not frequently cause hypercalcemia? Right, excellent. Hodgkin's lymphoma. Go back to the slide. This is a picture of multiple myeloma with a lytic lesion in the skull. Hypercalcemia is seen in 10% of all cancer patients. It's caused by either increased osteoclastic bone resorption or perhaps a combination at times of an impairment of renal calcium excretion. A lot of literature about the different characteristics of the parathyroid-like hormone substance that is produced. None of that's going to be on the emergency medicine boards. The treatment is pamidronate, which is a biphosphonate that impairs osteoclast. It's undeniably the best treatment. It's probably most of us would not be starting it in the emergency department. We'd be treating the patient with saline and Lasix if they had acute hypercalcemia. It's seen frequently in all the conditions that I listed, but not in Hodgkin's disease. That's an infrequent cause of hypercalcemia. We end on a hematologic question, which is a question about which of the following is not a characteristic of autoimmune hemolytic anemia. And this is a picture of with a lot of nucleated red cells and a lot of reticulocytes, which are small with homogeneous hemoglobin, and there'll usually be a number of target cells also in autoimmune hemolytic anemia. I doubt the boards are going to give you a slide and ask you what type of anemia it is, but just so you know, these are nucleated red blood cells and reticulocytes, the way they're seen on a Giemsa stain. Okay, let's vote. Elevated haptoglobin is the right answer. In patients with autoimmune hemolytic anemia, the haptoglobin will usually decrease. And you get all the markers of anti-red cell antibodies. You get both a direct and an indirect antibody test, which are renamed from the Coombs tests. You will see an increased reticulocyte, a decreased haptoglobin, an increase in LDH, and often an increase in bilirubin. And that is the end of hematology review. Hopefully we've hit the things that the boards are most likely to ask.